a quick little overview about our patient, Susan Watson. She told us that she prefers to be called Susan, so I'll be calling her Susan throughout the presentation. So Susan is a 75-year-old female who lives in North St. Louis County. Susan was a retired dental receptionist. She was a dental receptionist for 35 years, but she had to retire due to troubles with obesity. She began using a motorized wheelchair, and she uses that to navigate around her home, and also in the St. Louis area, she uses it to get to the grocery store and do different activities such as that. Susan was an active member of her knitting club and her book club, but she stopped that due to increasing health risks. In addition, she's been having a hard time hearing, so she also felt that she wanted to step back from those activities due to her loss of hearing. Susan is a huge cat lover, and she has many cats at home that she loves to take care of. And she's also a collector and spends a lot of her time online shopping and buying things from the television. It's kind of caused some clutter to grow into her home, so it's hard for her to go through her power wheelchair and navigate around her home. So Susan, as I mentioned, lives alone in St. Louis County, and she doesn't have any spouse or children. She does have a sister named Dolores. Dolores is from Chicago, and she has 2 sons of her own. But Dolores is having a hard time coming to visit Susan because of her own health risks. Dolores has skin cancer, COPD, and depression. Susan does have a friend whose name is Sarah. Sarah does come to visit her monthly. However, Sarah has grandchildren and family of her own, so doesn't get around all that often to visit her. As I mentioned previously, some of Susan's family history: her sister has skin cancer, COPD, and depression. Her mother has breast cancer, depression, and anxiety, and actually passed away from breast cancer, and her father's medical history is unknown. So Susan was most recently hospitalized for pneumonia. This was her 3rd hospitalization in the past 3 months. So she was hospitalized for pneumonia, also COPD exacerbation, as well as gastroenteritis with dehydration. Susan was a breast cancer in remission for a while, but it's come back, and she also has cancer that has spread to the lungs and the bones as well at this time. So Susan's been having a hard time going through these aggressive treatments and has told this to her medical team, so the medical team decided hospice would be a good thing for Susan to do. However, Susan seems to not truly understand the meaning of hospice or the extent of the disease that she's going through. She also currently doesn't have an advance directive, which is something that the team should look at into the future. I mentioned some of Susan's medical diagnoses. You see them listed here. It's extensive, so it's important for us as a team to really look at Susan's main goals and focuses so that we can center our care to what Susan wants, because there's obviously a lot to look at.
Okay, so just kind of looking here, we actually got to meet with Susan and kind of see where she is sitting with all this overwhelming information. We got to kind of get to know some of her values and what she kind of wishes at this time. So her first goal was the #1 priority was just to stay at home where she is comfortable with her cats and just kind of finish her life where she is most comfortable. Number 2, she'd like to be independent as possible. She has a lot going on health-wise, and fatigue makes it hard to complete her activities of daily living, but she'd like to continue her daily routine as normal as she possibly can at this time. She has been noticing that she's been pretty lonely, so we'd like to kind of give her some more social support. She's also been experiencing a lot of pain, so she'd like to see a decrease in pain, especially in her lymphedema in her arm, and a lot of pain in her hips and her back. And then she'd also like to understand her diagnosis better. She expressed that she was having a lot of anxiety, just kind of overwhelmed with all this information being thrown at her. So we kind of compiled kind of a laundry list of our concerns. Obviously we have her physical diagnoses of breast cancer, type 2 diabetes, hypertension, COPD. She's also having a hard time hearing, which kind of overlaps her social wellness as well. She's having difficulty breathing and some fatigue, and as I mentioned, some lymphedema in her arm. In terms of her environment, she's having trouble interacting with her community due to lack of transportation. Right now she's just using her scooter to get around, which isn't always the safest. As well as within her home environment, she's having a lot of trouble getting around, and we're just kind of worried about her getting around within her home. In terms of social, she's having a hard time, kind of being just really lonely. She has a good family, but they're also really far away. And she hasn't been participating as much in her book club and her knitting club, so that's kind of an area of concern. Emotionally, she's having troubles with major depression, anxiety, and OCD, so these are things we definitely want to address and make her as comfortable as we possibly can. And then intellectually, we worry about her not having a primary caregiver to look after her while she's doing her ADLs and just making sure she's as safe as she can be in her home at this time. As well as Brianna mentioned, she's not super educated in her hospice care, so just making sure she understands, walking her through step by step in this process. And then also spiritually, she talked with her chaplain about her end-of-life wishes and didn't really seem super clear what path she wanted to take.
So based on Susan's personal goals, this is the IP team that we decided to create. So the social worker will basically act as the team leader and will be the case manager as well as oversee all the other disciplines. So the OT and PT will connect Susan with other resources in St. Louis, as well as reach out to her family and make modifications in the home environment so that she has an easier and more comfortable stay. The physician, doctor, and nurse will work to educate Susan on her diagnosis as well as on the care plan that we will create. The dietitian, pharmacist, and speech and language pathologist will work with Susan on her nutrition and pain management, and a marriage and family therapist as well as a chaplain will work as a support team for Susan. And because the ultimate goal is to increase Susan's health and wellness, she will be at the center of our team as well as her family and friends, who we hope will visit her more often. Hopefully her nephews will bring her sister down at least once a month. And as far as communicating goes, our team will meet once a week and will communicate continuously through a pager. And there's also an app such as the OMD app, which can be used so that health professionals can communicate about Susan's case in a safe and secure way. So they will be able to text, send pictures of x-rays, as well as share resources on different treatment and intervention ideas. And the social worker, since communication is so important in this case, so that Susan can still be a part of the team and make her own decisions, the social worker will work as a liaison between Susan and the rest of the team, so she can communicate her concerns and goals, and then the social worker can bring that back to the team and we can address those goals in our care plan. And as far as roles and responsibilities, it is the IP team's goal to make sure that this is client-centered care and that Susan can make her own decisions. So since the ultimate goal, again, is to make sure that she is increasing her health and wellness, it is the IP team's goal to help her reach her goals and be as healthy as possible.
Based on Susan's goals and conversation with Susan, the team have a treatment plan for Susan. Firstly, the team will help Susan to identify a caregiver. So the team approach will be taken for caregiving. In this caregiving team, her friend Sarah and home and community-based service provider and the hospice nurse will be included in this team. So taking team approach can help to prevent caregiver burnout, and they will help Susan with ADL and IADL. Also, as Sarah is one of the caregiver, the IP team will provide emotional, psychological, physical support for her, and Sarah will partnership with a home health provider, which can be applied in Missouri Department of Health and Senior Services. After applying this service, Susan can pay professional who may come multiple times a week or daily if needed. Then the team will provide patient and provide education for Susan and her family. As Susan has less knowledge about hospice and breast cancer, the team will provide this type of education for her. Also, this education will help her family to learn more about Susan's situation. Also, the team will provide care planning education and provide support for family and caregiver. So after having the care planning education, even though this case is terminated, the family also have the ability to continue the care planning. And then the team will introduce the advance directive and help them to fill out advance directive Lastly, the team will provide education of the resources, so the family and student can learn about how to get access to resources and how to apply these resources. Then the team will focus on Susan's from psychological aspect. The team will provide individual therapy and group therapy for her. For her depression and anxiety, the therapists will provide psychoeducation for Susan to let her know more about depression and anxiety. Also, Susan can learn more about the therapy which we'll use in the individual therapy. So therapy will apply cognitive behavior therapy and life review therapy for Susan, and in the process, Susan will work with therapy to create a product like album or video or life story journals. For her hoarding and OCD problem, the therapy will use motivational interview for her because Susan is defensive to clean up her home and collection in her home, make the home environment unsafe. So the therapy will use MI to encourage her to have the change of her home environment. Also, therapy will concern about the relationship between hoarding disorder and her depression. And then the therapy will refer her to group therapy. One is education of illness support group, and the other one is CBT group for depression. From social aspect, the team will contact with Metro Ride and OAT's transportation service and apply for it. So after solving the transportation problem, Susan can re-engage in book and meeting club, and also she is able to participate in support groups. This will help her to feel social engagement, and also the team will help her to address hearing aids, so she can hear others' conversation and she will not feel isolated. Also, the team will explore and contact local agencies which provide the regular home visit for Susan. And from the spiritual aspect, the team will contact with a local church and discuss possible plan to explore whether the chaplain can meet with Susan at her home. Also, if Susan gets back to the church, the members from the church can help her to get transportation, and this will also benefit her social aspect.
In addition to Susan's psychological, social, and spiritual needs, our team would work with her to improve her quality of life with respect to her illnesses and their accompanying symptoms that she doesn't have to suffer through. This focus on preventing and relieving suffering and achieving the best possible quality of life for Susan falls under the interdisciplinary specialty of palliative care. One key component of Susan's palliative care is an accurate periodic assessment of her symptoms. These assessments can be given by any member of Susan's care team and would help us understand what we can do to best address Susan's symptoms as they change throughout the progression of her illnesses. The PEACE assessment is one such assessment that can be administered by a caregiver. PEACE is an acronym for physical, emotive, autonomy, communication, economic, and transcendent domains of quality of life. It checks in with Susan concerning a spectrum of factors such as pain, appetite loss, incontinence, nausea, breathing problems, feeling sad or anxious, not feeling in control or understood, or feeling like she needs more support. Frequently checking on these factors of Susan's quality of life will help guide our physical interventions for her over the course of her care. The assessments also serve to remind Susan that she's being listened to and provides opportunities to reassure Susan that her symptoms will be addressed as they develop. Susan already faces a number of symptoms as a result of her ailments that we know of, and will be expected to face others over the course of her hospice care. This list of symptoms most notably includes dyspnea, pain, fatigue, nausea, depression, and malnutrition. While medication like a low-dose opioid and an anxiolytic can be used to address Susan's symptoms over the next few months, Susan already has a long list of medications. Increasing this list can also increase her risk of adverse effects as a result of drug interactions. Also, having a long medication list is known to lead to issues with adherence. Before we turn to pharmaceutical interventions to address Susan's symptoms, our team feels it's best to keep those tools in our back pocket as we first try non-pharmaceutical techniques to help her manage her symptoms. Susan's difficulty breathing as a result of her COPD is one of the more distressing symptoms she faces, and is one that might worsen over time. Addressing Susan's dyspnea is one of our team's and Susan's priorities, since dyspnea is identified as the most important variable influencing the will to live among terminally ill cancer patients. Dyspneic patients frequently report social isolation as a consequence of reduced activity levels. Pursed lip breathing is one technique we can teach Susan to help with the shortness of breath. This technique keeps pressure up in the airways, so Susan loses less breath and keeps the airways from collapsing. The technique includes breathing in through her nose and breathing out with her lips pursed. Pain is another distressing symptom for Susan, which she suffers now in her hips and back. One way we'll address this is by refitting of her wheelchair. Susan has an increase in pain from prolonged sitting, so a wheelchair that fits more optimally may help decrease this pain. Along with this, Susan can be taught to do weight shifting activities to prevent pressure sores and pains from decreased movement. Energy conservation techniques can also be used to help decrease shortness of breath and decrease pain. This includes proper transfer training and adaptive devices from the OT and PT. A home evaluation can also be performed. After this evaluation, some beneficial adaptations can be a mobile commode, adaptive shower equipment, and other energy conservation techniques to help with dressing and bathing. Lymphedema has also been an issue for Susan, causing her some pain. Her sleeve doesn't fit well, so she would benefit from a refitting of the sleeve. In addition, lymphedema massage can be added into physical therapy treatment to help control some swelling and discomfort. The speech-language pathologist can also be an asset to this team to help with swallowing techniques, such as a chin-tuck posture to decrease the risk of aspiration. This is important given the difficulty of swallowing that accompanies the interesophageal stasis noted by the speech-language pathologist.
So another thing Susan needs is an advance directive. She currently doesn't have one right now. And advance directives are put in place when a patient is able to make decisions for themselves in the event that the patient can no longer make a decision in the future. So something that Susan can use is Life Choices book to help communicate her end-of-life wishes, and there's a specific one used for Missouri. These advance directives include both the durable power of attorney for healthcare and the living will. So the DPAHC is something where Susan can give the power to make decisions for her to someone else in the event that she can no longer make those decisions. And a living will is more in the case of what Susan wants to happen if she can't make those decisions, such as if she's terminally ill, it may say something like not making any heroic measures to try and save her. Someone who can help with this is the chaplain, since she was now getting reintroduced to her spirituality, and if she needs help from an elder law attorney, she can get that as well.
So for student resources, some have already mentioned about the transportation resources called Reservice OATs transportation, and also Susan can apply for the volunteer drivers to get her to some places. And then the service resource is in-home service, and also the meal on wheel to provide her meals. Except for the resources, the team have the referrals for Susan. The first referral is to refer to dietitian, as Susan is rely on convenient food and fast food, so the dietitian will help her to have a better education about healthy meal, healthy diets, and also help her to come up with a easier recipe to help her to follow to cook something. And the team will connect to lawyer to refer her to address advanced planning. Also, the team will refer Susan to audiologist for her hearing aids.
So as far as Susan's satisfaction, due to our interventions, all her goals were addressed. So she's now able to stay at home with her cats. She's more independent with her ADLs. She's also more socially active, and she has told us about decreased pain and fatigue, and she also better understands her diagnoses.
So a quick picture of our routine. And then just a couple points to wrap up. We had a really good experience working through this case. We had 3 team meetings and just kind of split to kind of do independent research and would come together, and so we had that constant communication. Overall, it's a pretty respectful environment to like hear everyone else's perspectives, and overall we've kind of realized that geriatric cases are very complex. There's a lot of issues that could potentially be addressed, but at the end of the day, the most valuable ones are the ones of the client. And that it was also it was difficult to schedule meeting times, but you have to make it work for the patient, as we will have to do in the future as well. So at this time, we'd like to open up for any questions.
Questions?
How did you determine your priorities with the patient?
Well, when we were all kind of reading our case, there's kind of little subtle hints in it, and like when people were talking to Susan in the case, she would kind of say things like, oh, I want to be home with my cats, like I want these certain things as we were going through it, and we kind of honed in on that.
I had a question for you. You had a chart that showed a box that said connectors and it had OT and PT.
Yeah, so,
what's connectors? I hadn't heard that before.
Oh, sorry. I was just saying that OT and PT would talk to Susan about and connect her with resources like in St. Louis. So, for example, the OT could provide resources for getting medical equipment or
And like refitting of the wheelchair,
yeah, refitting
which
the
we thought was
wheelchairs.
good sort, might have been a source of her pain that she was having, especially.
Or people who like make modifications in that home, like people who can make ramps into her home instead of using stairs, or people who can provide grab bars, or something that can make it easier for her to stay in her home for a longer period of time rather than going to like a nursing home or a skilled nursing facility.
The other question I had was, you listed hoarding and OCD. Is that, did you go to that from the fact that it said her home was cluttered?
Yeah,
Is that how you got to that?
because the brief summary for this case, it points out it's OCD, but I feel that in this case, according to the DSM-5, I think she maybe more on the hoarding perspective of the OCD. So.
I guess my only question seemed like some positive outcomes, the plan you made. How did you reconcile that with the hospice diagnosis and referral?
I think the hardest thing for Susan was not knowing, and she wasn't even given the chance to accept her diagnosis because she didn't understand the diagnosis. And we were hoping with the education we could provide and the comfort we could provide, which was something that seemed very important to Susan, reading through, kind of helped us to figure out if she was educated, we can make her feel comfortable. Hopefully she'd have a better outlook.
You obviously worked very hard. It was very nice. So congratulations for being good team. Thanks to you all too.
Thank you. I'm staying in town. Are you in your Our band, all
We
right.
would meet for the.
All right.
So I wish you the best.
Thank you very much. Yes, indeed. Always fun.
Bye
now.
Thank you. Good luck. Have a good night.
Bye now.
Good for what?
That was one of the best things I've seen. I've been doing this, what, 3 years or whatever? That's one of the best. Because of the integrated nature and the understanding.
Can you wait for us? We got sorry.
We'll call you. You know, just that integrated nature. I like that it just was their discipline. Somebody else might have talked on it. Love that. I thought that was amazing. No, this was really one of the
You can
best.
see always
I've
the
ever
interaction between us, between the
Yeah.
presentation.
Yeah, so the first one was really good. And I kind of including that.
So ranking wise, this team
Oh,
is
yeah.
number one.
Yeah, completely.
Yes.
Yeah, they did.
Yeah.
The first team just kind of
threw everything at the wall and.
The other thing I loved is some of their models, you know, how they
Oh,
focused
yeah.
on social, physical, environmental, and then they had that peace thing. I thought, oh my gosh,
The
really
first,
good.
the first one, we feel like each one do his slide
Exactly,
and copy it in
Exactly.
the presentation.
exactly, and there was
It's,
just so patient-centered in this,
No.
so
No, funny, I wrote that down too.
It was
I like,
very, I know, I wrote down, it was very paternalistic, and, you know, we know what's best, and here it is, and here we got this place, and this place, and this place for you.
I thought the first team kind of did say, you know, this is kind of what we think, but this is what she wants, so here's where we went. I thought they did better than some teams I've seen, but this team was